I'll be talking for measuring glycemic variability in clinical practice. So before I say measuring glycemic variability is useful, to answer certain important questions. And these questions are, what is glycemic variability? And is it important risk factor for complication? Do we have data about impact of glycemic variability? Is it possible to identify and measure glycemic variability in real clinical practice? And is it possible to modify glycemic variability? The answer of this question is yes. That means we need a parameter called glycemic variability in our practice. So let me give you answer of these questions one by one. Why we need a more matrix, more parameter? Because we all know that HbA1c is not sufficient. It does not provide information about inter and intraday variability. We know there are certain parameters which interferes with HbA1c measurement. It does not help us to recognize hypoglycemia, and on top of that we all know that HbA1c is having ethnic and racial difference, and based on just HbA1c value it will be very difficult for us to plan a personalized treatment protocol for the patient. So we always need a matrix which is beyond an HbA1c. Initially when we were managing diabetes, we were focusing on fasting and HbA1c, but now with the availability of data, our focus has shifted to some other parameter as well, like hypoglycemia, and recently glycemic variability, which is one of the important determinants and one of the important aspect which we need to consider while managing diabetes patient. So now world is moving from this triad to hexad, which include fasting, HbA1c, anytime hypoglycemia, nocturnal hypoglycemia, and glycemic variability. So what is this glycemic variability? So glycemic variability refers to fluctuation in blood glucose level, which include both peaks and trough, which include within day and day-to-day variability. And because of this glycemic variability, people are having more oxidative stress, and because of that it leads to complication. So glycemic variability is really very important factor. Let me tell you, person with similar HbA1c can have a different glycemic profile, and that can be evident with this example. If you see in this example, 3 persons are having HbA1c of 7%, but if you measure glycemic profile of these 3 persons, you can see time in range is 18% in patient 1, while 60% in patient 2, and it is 100% in patient 3. So HbA1c is not giving you an idea about glycemic profile of the patient, and because of adverse glycemic profile with similar A1c, it can contribute to complications. So we need a measure of glycemic variability. We need to identify glycemic variability in a patient with diabetes mellitus. We have learned lesson from a landmark trial like ACCORD and ADVANCE. So all trials were telling us that hypoglycemia is also one of the major determinant of diabetes management, and hypoglycemia is associated with adverse outcome. And when persons are having higher glycemic variability, they are also at higher risk of hypoglycemia as well. So it is very important for us to identify which persons are having higher glycemic variability. Okay. So do we have any data about impact of glycemic variability? Definitely yes, we are having data. It was really a very beautiful study done by Shu et al. What he has done? He has compared maize. What is maize? Maize is one of the metrics to measure glycemic variability. So he has compared maize with other risk factors for cardiovascular disease. And what does his study tell us? That maize is as important as smoking. So it is a very important risk factor. And maize is more important than hypertension, hyperlipidemia, and age. So glycemic variability is very, very, very important risk factor which is associated with adverse outcome. Do we have study at a cellular level? Yes, we do have study which are telling us that glycemic variability can lead to endothelial dysfunction. And this was very nice study done by Quagliamaro et al. What he has done, he has shown that cell death, that is apoptosis, is quite high in human umbilical vein endothelial cell when the cell was exposed to variable blood glucose level, that is between 90 to 360, as compared to cell were exposed to high blood glucose level. So when cells were exposed to variable blood glucose level, the rate of apoptosis is quite high. On top of that, you see the activation of protein kinase C pathway is 80% higher than cell kept at a higher blood glucose level. That means the person are having higher glycemic variability, his likelihood of developing endothelial dysfunction is quite high. Again, there are few studies which are telling us that glycemic variability is associated with marker of endothelial and cardiovascular damage in diabetic patient. In patient with diabetes, high glycemic variability has been associated with cognitive impairment, and in patient with type 2 diabetes mellitus and acute myocardial infarction, increased risk of mortality is observed in patient with higher glycemic variability. So high glycemic variability do lead to adverse outcome. Again, there is one study which has clearly shown that if you reduce time in range by 10%, it increases the risk of microvascular complication like retinopathy by 64%, nephropathy by 40%, and neuropathy by 25%. Not only that, this glycemic variability is also linked to macrovascular complication. Higher glycemic variability can affect surrogate marker of macrovascular complication like carotid intima media thickness. So glycemic variability not only affect microvascular complication but also can affect macrovascular complication. We all know about DEVOTE trial, and if you see a pre-specific analysis of DEVOTE trial, what they have shared, they have said that if there is increased fasting glycemic variability, and if people are having more fasting glycemic variability, they are associated with significant increased risk of severe hypoglycemia, MACE, and all-cause mortality. So not only that, even a short-term glycemic variability in an hospitalized patient is also associated with adverse outcome. And this was really very nice study which has shown that when you are having short-term glycemic variability when patient is admitted, it is associated with increased mortality and hospital stay. So we have numerous data about impact of glycemic variability and diabetes related outcome. Okay. Do we have any measure of glycemic variability? Yes. We have a various metrics for measuring glycemic variability. Some of the metrics measure the amplitude of glycemic variability. These are MACE, the standard deviation, CV, low blood glucose index, and high blood glucose index. There are certain other metrics which measure the timing of glycemic variability, and in clinical practice, we are using them a lot with the help of CGMS, which gives you not only amplitude, but even a timing of glycemic variability in a person. Then based on that, people have defined time in range, time above range, and time below range. And this CGM based data on glycemic variability help us to plan a personalized treatment for diabetes patient. So definitely it's now become very easy to assess glycemic variability even on clinical practice. Do we have any guidelines based on glycemic variability? Let me tell you, initially we do not have any guidelines, but after 2019 we have a specific guidelines based on the glycemic variability. And in 2021 ADA says that CGM as an important tool for hypoglycemia prevention. So definitely it is time to address glycemic variability in our diabetic patient, and we do have guidelines. If you go by ATTD 2019 guidelines, they have clearly given recommendation on time in range for different diabetic population. I'll not go into detail of recommendation. What I mean to tell you that now we are having recommendation available for glycemic variability as well. Do we have any way by which we can lower glycemic variability? Yes, we do have. By intense lifestyle modification and with the use of newer diabetic medication, maybe oral or injectable GLP-1 receptor analog or a newer insulin analog, we can definitely lower glycemic variability in a diabetic patient. And glycemic variability data is not only beneficial to physician, but it also beneficial to patient as well. How? So measuring of glycemic variability like ambulatory glucose profile clearly illustrate the pattern in glucose level. These enable HCP to detect potential problem like hypo, hyper, and glycemic variability more quickly. They don't have to do that calculation. So the measure like AGP is really very helpful to the physician, and this amount of data is not available with SMBG and or HbA1c even with more engaged patient. Okay. Now how it is beneficial to the patient? AGP graph is very simplified graph. It is presented in a simplified way that patient can easily understand. And based on that understanding, I have seen patient modifies their behavior and they become more aware about glycemic fluctuation. So it is very important parameter in clinical practice. Yes, we don't need to measure glycemic variability in all the patients, but there are certain situations in which measuring glycemic variability is really meaningful and important. These are patient with HbA1c on a higher side, but fasting is quite normal. Patient with repeated hypoglycemia and hypoglycemic unawareness. Patient with type 1 diabetes mellitus having A1C on a higher side and having recurrent diabetic ketoacidosis. Patient with brittle diabetes before and during pregnancy. An elderly patient who are at very high risk of hypoglycemia. In this clinical situation, definitely we need to measure glycemic variability and we need to plan a personalized treatment based on the data. So if I summarize my part of the presentation, glycemic variability in addition to HbA1c result, may be more reliable indicator of glycemic control than HbA1c alone. Glycemic variability and HbA1c is complementary to each other. It gives you a lot of information. Okay, and we all know that glycemic variability is significant risk factor for development of vascular complication. We have clinically useful tool like CGMS by which we can assess glycemic variability, and result of glycemic variability gives us an opportunity for greater personalized therapy for diabetes management. So when you know that glycemic variability is important risk factor, when you know that glycemic variability is associated with adverse cardiovascular outcome in a diabetic patient, when you know that it can be easily measured nowadays with the use of CPM, now when you are having guidelines for glycemic variability and when you are having treatment option available to use glycemic variability in a diabetic patient, definitely measuring glycemic variability is useful in a diabetic patient. Thank you.
So much. Start to the for not useful glycemic practice, have none other tackle that. The physiologist, currently consultant, diabetologist, hormone, diabetes, thyroid, and hypo. He's had several publications and also authored a chapter on diagnosis of neuroendocrine. He's of ESI TYSA and of course has best paper presentation travel grant of national. Without much ado,
so much. Before I proceed, so I'll be thinking about measure not useful. So my outlines are have a brief introduction followed by the target glycemic variability, what are the evidences, from the biochemical abnormalities, complications, and risk of hypoglycemia, and are there any available pertaining to which targets the glycemic variability, what are the shortcomings of glycemic variability, how to overcome those shortcomings. I'll conclude in the end. So just before that, AD has recommended HbA1c and CGMS device as well as SMBG for monitoring of blood glucose. So CGMS has been specifically recommended patients who are on intensive therapy and there are risk of hypoglycemia in them, and in type 2 diabetes who are on intensive therapy, CGMS devices to assess the risk of hypoglycemia. So that HbA1c is the weighted average of past 3 months, and it can be reported as an average glucose depending on the percentage of HbA1c which is by Nathan et al. So in HbA1c era, that is last 28 years of HbA1c, by reducing the percentage of HbA1c, there has been a remarkable decline in the risk of complication when we decrease the HbA1c, as it has been shown in trial and followed by addict trial. So we know that HbA1c is a gold standard and it is very important for assessing the risk of diabetic complication and also overall glycemic control. And HbA1c has been a target of many guidelines and recommendation, also a diagnostic criteria for diabetes. But HbA1c has many fallacies. As sir has already explained, HbA1c does not detect the variability. As we can see here, the HbA1c has many phases. For the HbA1c of 7, we can see the image 2 and 3, there is high variation. Image 3, there is a very high incidence of hypoglycemia. So to counter this problem, which is by HbA1c, glycemic variability has come up last 50 years. So we know that glycemic variability is a variation over the time. So this variation can be a long-term glycemic variation and short-term glycemic variation. So we can measure long-term variability by CV or SD or variation independent of means. And short-term variation we can measure intraday, interday, like we can use MAGE, Conga, and time in range parameters. What are the measuring method for glycemic variability? That CGM can be very well used. Besides CGM, we can use the SMBG also, glycemic variability, and flash glucose monitor can also be. So these are the complex formula by which we calculate glycemic variability. However, there are large number of matrices available. Does this profusion of information create confusion? Because the clinical interpretation of matrices remain difficult. Just simplified glycemic variability matrices can be classified into short-term glycemic variability, most important of which is coefficient of variation, which has been recommended by ATTD, and it has been shown that by Monir et al. That the coefficient of variation of glycemic variability is less than 30%, and the risk of hypoglycemia is less. So glycemic variability be assessed in context of hypoglycemia. And what are the long-term glycemic variability parameters? So we know that we can measure fasting postprandial variation in HbA1c. Long-term glycemic variability is a reflection of ambient glucose in the blood, and can be long-term variability markers of glycemia. So should we target glycemic variability? What are the biochemical abnormalities associated with glycemic variability? So we know that glycemic variability associated with hypo or hyperglycemia, by causing these changes, there is an increased risk of inflammation, there is risk of oxidative stress, and other inflammatory cytokines are also upregulated. Because of that, there is an endothelial dysfunction and damage to the organs, and possible risk of complication, macrovascular or macrovascular. What are the studies suggested? So what are the link of glycemic variability with biochemical abnormalities? So there are few studies. Study which was published in 2008. So they have shown in patient, as the glycemic variability increases, age increases, there is risk of urinary excretion of inflammatory markers like isoprostane increases significantly. Where another study with a similar methodology and large number of participants, a more specific method measure isoprostanes. They have not shown any association of increased risk of inflammatory markers excretion in the urine versus MAGE, and regression line was also not be drawn. What are the link of complications with glycemic variability? So this meta-analysis which has shown risk of complication, macrovascular complication with glycemic variability, seven study in which RCDs were also included. So in this forest plot, we can see three studies, they have a neutral effect on CV outcome, and 4 studies, they have shown a negative association between myocardial infarction and glycemic variability. Hence, author has concluded that it is difficult to reach a conclusion due to small number of included study. Again, the short-term glycemic variability association with microvascular complication. So you can see the level of evidence here. Level of evidence is only one in study by Kilpatrick et al. As well as Service. So in that they have analyzed post-hoc analysis of disease trial. So we can see here the risk of microvascular complication slightly, because as we can see here, the odd ratio is not more than 1.5. It is just slightly increased. You can say that short-term glycemic variability may or may not be associated with microvascular complication. Similarly, Kilpatrick et al., they have shown the slight increase or may not be a risk of short-term variability with macrovascular complication. Again, this study has shown short-term variability with macrovascular complication. The ADAG study, conclusion of the study was CGMS was not more informative, and it was not better than the HbA1c and frequent measured SMBG. So you can see the Z score, which was a correlation between various parameters, variability. So HbA1c as well as mean blood glucose was a significantly better marker than the varices and indices of variability. Again, the short-term glycemic variability and risk of microvascular complications of Patrick et al., they have shown that between day variation, that is short-term variation, is not associated or no influence in either retinopathy or nephropathy. Again, this study, they have seen the HbA1c variability and risk of microvascular in type 1 diabetes. The risk of retinopathy as compared to HbA1c variability after adjustment of HbA1c what was similar than the mean blood glucose. Study which is meta-analysis, and this study it has been shown that the long-term glycemic variability is it is associated with macro as well as microvascular complications. So there has been a significant association with HbA1c variability and overall mortality, renal diseases as well as cardiovascular disorder in type 2 diabetes. Similarly, retinopathy, renal disease as cardiovascular disease in type 1 diabetes. However, the author concluded that most of the studies are retrospective with a lack of adjustment for poor profound confounders, and thus the result remain questionable. In the post hoc analysis of ACCORD trial, they have shown that there is an increased risk of mortality when we have even HbA1c of less than 6.22. If the variation is more, there is more risk of mortality. So bringing all this data together, it seems that the long-term glycemic variability is strongly associated with adverse outcome in patients with diabetes. However, debate remain continue as there is no one can confirm that the matrices of glycemia is causative factor for cardiovascular or all cause of mortality, or just a simple marker of unsatisfactory adherence to lifestyle measures or medications. So coming to critical illness mortality and association with glycemic variability, study it has shown that variability is associated with the increased risk of mortality in critical ill patient. However, there is another study which has compared in critical illness the risk of mortality in non-diabetes is increased. However, in diabetes the risk of mortality does not increase variation in. Another table which is very busy, but here the post hoc analysis of advanced trial, the risk of long-term variability in glucose is associated with macrovascular as well as overall mortality. And DEVOTE 2 trial post hoc analysis, risk of increased glycemic variability is associated with hypoglycemia. Studies, the sample size is questionable and the quality of data is also questionable. So clear-cut data confirming the glycemic variability as an independent risk factor for glycemic are still lacking. To study HEART-2 trial and DIGAMI 2 study, they are showing no association of glycemic variability with the complication of diabetes. So again, HEART-2 study is showing no association with glycemic variability with myocardial infarction. As we can see, after randomization, even the fluctuation was more in patients who were given only basal insulin. The risk of cardiovascular outcome was more different. Again, flash sugar trial, they have compared basal bolus insulin with glupulin, that is a GLP-1 analog with basal insulin was compared, and we can see that by using glupulin, the various indices of glycemic variability have been reduced, but seeing the inflammatory markers, there was no difference in the oxidative indices both the arms. So we don't know that whether we control the glycemic variability, the inflammatory markers subsides. So association of hypoglycemia is very strong. So glycemic variability should be assessed the view of hypoglycemia. As the glycemic variability increases, there is risk of hypoglycemia increases, and hypoglycemia we know that it is very important and it enhances the clinical interpretation of HbA1c. When we combine HbA1c and hypoglycemia, these two parameters can be very useful in clinical practice and decision making even without CGMS. And we know that the hypoglycemia is associated with emergency visit and seizures, death, and it is also associated with cardiovascular disorder, dementia, and poor quality of life. So in nutshell, what are the evidence for utility of various parameters compared to glycemic variability? So rate of evidence for metabolic as well as oxidative stress. We know that short-term variability is associated with increased risk of cardiometabolic risk and increased oxidative stress, and hypoglycemia also is associated with increased. However, the long-term glycemic variability is not associated with increased risk of cardiovascular markers or mediator. However, when the hard points of adverse outcome are considered, like hard points in the form of myocardial infarction, hospitalization, so long-term variability with hard outcomes, Also same way, short-term variability is a question mark. So HbA1c and hypoglycemia and glycemic variability, when we compare mortality, when we increase HbA1c, when we increase glycemia. However, there is a possible relation with glycemic variability. And when we add hypoglycemia, glycemic variability, hypoglycemia is very easy to assess and important in decision. So we have non-pharmacological as well as pharmacological treatment. However, those pharmacological studies are very limited and there is very small sample size. Shortcomings of glycemic variability, the CG called the high cost, anxiety, no consensus matrices. There is limited data on short-term variability and complication risk, and long-term variability data exists, but interpretation of indices remain elusive. There is no well-defined treatment options. How to overcome this problem? There should be a formal RCT examine the relationship glycemic variability and hard endpoints like retinal outcome, and further we'll need a drug and study design that altered the variability with identical HbA1c. And role of insulin, we know that antioxidant decreasing antioxidants of study which we are planning, we hold from that any harm, not be used in harm. Further, common matrices for glycemic variability added upon. To conclude, glycemic variability, there is unclear data on diabetic complications, and when we reduce glycemic variability, we don't know we reduce the diabetic complications. Hence, measuring glycemic variability in clinical practice may not be.
Thank you. I have Dr. Dalwadi, Bartle, or Dr.
I go with the slide of my 70% slide is long-term glycemic variability has shown adverse outcome, and completely agree with him. So glycemic variability, I'm not saying that it is not needed. It is definitely needed. Gives us a lot of information beyond HbA1c and help us to manage glycemic parameter in our diabetic patient. Yes, it is emerging parameter. Definitely it is an emerging parameter. So we need a larger data and long-term data regarding benefit of it. But definitely clinically in our practice we see a huge glycemic variability is associated with poor quality of life. And when patient is having a lot of glycemic variability, blood sugar level of 50 and 350, this definitely impacts the symptoms of diabetes as well. So lowering glycemic variability clinically is meaningful, it is important. Yes, regarding lowering glycemic variability and reducing macrovascular complication, definitely we need a larger and long studies. So definitely in clinical practice it is useful parameter.
Great, thank you. Comments from the audience, or all agree that glycemic, all the yes, that not a useful parameter. Talking about glycemic, have a full house on, or a majority of, for the validity. Yes, a lot of work needs validate parameters out, cost self-pay, not rule. Glycemic, go with